finally, we sit down with Dr. Brad McGregor, who's the clinical director for the Lenk Center of Genitourinary Oncology, medical oncologist at Dana-Farber Cancer Institute, who will share his perspective on the biggest prostate cancer studies this year. Dr. McGregor, thank you so much for being here today.
Thank you for having me.
Oh, sure, of course. So let's kick things off with some of these studies looking at PARP inhibitors in prostate cancer. So we have the PROfound trial that's looking at olaparib versus enzalutamide or abiraterone for metastatic castration-resistant prostate cancer with HRD gene alterations. So what do you think we can be expecting with these data, and how could they, kind of evolve the role of PARP in this setting?
So I think when you think about PARP inhibition, there's been a plethora of data presented in the past several years really highlighting that DNA damage repair is common in prostate cancer and that this is something we could potentially target. We've already heard results of the PROfound trial when they're screening patients, up to 30% of patients have homologous DNA damage repair alterations. So this is not a minority of our patients, and so we've really been looking to try to take advantage of this overall. And there's been multiple phase 2 trials even presented just here at ESMO with the Galahad trial, looking at different subsets of these. So the Galahad trial really focused on those with biallelic mutations, either BRCA or non-BRCA. And what they showed in those patients with the biallelic BRCA mutations, response rates were over 40%. Less so with those that were non-biallelic, less than 20%. But there's a lot of discussion about what does that truly mean, looking at PSA. You may be helping out a certain clone, but not all clones, and where does this happen? And so really looking long-term overall survival data, everything is going to be really important. And so the PROfound trial is really the first time we've taken these patients that have these mutations and compared them versus a standard of care. So in this case, either abiraterone or enzalutamide, and it's really the largest trial. We have a lot of data about which mutations there are and potentially be able to better ascertain, maybe not all DNA damage repair mutations are the same. 30% have mutation, but maybe it's those with the biallelic BRCA or those with another mutation that really derive the benefit from PARP inhibition. I think it's really exciting for our patients as we sort of look forward to trying to personalize the therapy and deliver them the most effective therapy for their specific type of cancer.
That's great, and it goes on. I was just going to say it's really exciting to see prostate cancer kind of have a lot more targeted therapy approaches and some of that research emerging.
Right.
Definitely. Great, thank you. Now, how about the randomized CARD study of cabazitaxel versus abiraterone or enzalutamide in metastatic castration-resistant disease?
So yeah, I think when you think about prostate cancer, while there's been a lot of developments, at the end of the day, there's really, sort of very few classes of drugs that work for prostate cancer. We have the backbone of androgen deprivation therapy, and then we have sort of these more intense androgen deprivation therapy, be it abiraterone, enzalutamide, apalutamide, darolutamide, and then we have radium-223, taking advantage of those patients with predominant bone mets, no visceral disease. Then we have, in the United States, we have Sipuleucel-T for that long-term immunotherapy, and then we have chemotherapy. And so we know when we see a patient or talk to a patient, there's generally people call it chemophobia, that patients don't want to go to chemotherapy. You have all these other targets, and so it's always very tempting that, you progress on abiraterone, why don't we try enzalutamide? Or you progress on darolutamide, let's try abiraterone. And so there's this temptation to sort of go with that because we think it's going to be easier for the patient. Patients have a better quality of life and feel better. So this is the first study that says, that's great, but what are the impacts on our patients? And what it really shows is that, when you have a patient who's not doing well with that second generation hormonal manipulation, that chemotherapy really should be your preferred option because we're doing our patients a disservice by continuing with the novel hormonal manipulation, specifically when they have a poor response to that first line of therapy.
Great, those are great points. Now, we also saw an updated analysis from the Spartan trial looking at overall survival in non-metastatic castration-resistant disease. So could you speak to this trial and the data that was presented?
So I think when we think about M0CRPC, which I think is probably a moving target with the advent of new therapies, I think that we've had a wide variety of data presented just the past year now with data for apalutamide, darolutamide, and enzalutamide, all showing improvement in metastasis-free survival in patients with M0CRPC. And so this was, given the long follow-up needed to show overall survival overall survival has not been reached. So this is the first look at overall survival, and what it did show is there's certainly a trend towards improvement in overall survival, although given the statistical design, the p-value wasn't quite statistically significant, but certainly I think it may be clinically significant. I think there's been a lot of talk of, well, how applicable is this in the era of PSMA PET, right? And so we're finding more therapies earlier. Does M0 CRPC really exist? And I think this study says you're M0 by conventional imaging. So if you have a patient M0 by conventional imaging, but does have a MET on PSMA, I think this study is very much applicable. And so I think these data are actually going to be very applicable as we move forward and we start looking at patients that are PSMA PET positive and maybe conventional imaging negative. And these studies are really going to help guide that care.
Great, thank you. Just kind of looking overall at all the research that's been presented this year at ESMO, what do you think this really says about the way the prostate cancer armamentarium is evolving?
So I think at the end of the day, we just need to continue to develop new therapies, new biomarkers. I mean, I think that's what the Profound study is looking at, is trying to find those biomarkers. Not all DNA damage repair mutations are the same. And really trying to advance care and find novel targets, because at the end of the day, unfortunately, when someone has metastatic prostate cancer, we're very good at treating that. It's very difficult, not impossible to cure that. And so we need to find those new targets to hopefully get that long-term control of disease, potentially even eradication, and something to augment that of ADT.
Wonderful. Thank you so much, Dr. McGregor. This was great. Really appreciate you coming by today.
Thank you.